Hi, everyone. Thank you for joining us. My name's Libby Levine. I'm a nurse practitioner at the Columbia University Medical Center in New York at their MS Center. And on behalf of Neu-Ring, I would like to welcome you and thank the IOMSN for hosting this webinar. For those of you that don't know, the International Organization of MS Nurses, or IOMSN, is the only international organization focusing solely on the needs and goals of professional nurses anywhere in the world who care for people with MS. If you're a nurse who cares for MS patients, please check out the website and consider joining the organization. There's lots of great resources online available to help you help your MS patients. We'll be posting the link at the end of the webinar. Um, this presentation is designed to provide general knowledge of the topics discussed. Individual circumstances should be discussed with your provider. So if you have a question that comes up that's specific to you and your circumstances, please feel free to share this presentation, which, by the way, will be recorded with your provider. At the end of the session, we'll have a question and answer session. Um, as such, you'll notice that you're muted. So if you by accident become unmuted, please mute yourself or we'll mute you so that you don't accidentally disrupt Dr. Shah's presentation. We're going to try to get to as many questions as we can at the end. Speaking of which, if anyone has a specific interest in hearing about MOG antibody disease or neuromyelitis optica spectrum disorder and pregnancy data, please send a Q&A so that we can be sure to include that in the presentation. So without further ado, I'd like to introduce our speaker tonight. Dr. Anna Shah is a neurologist specializing in MS and neuroimmunology at the Rocky Mountain MS Center at the University of Colorado. She completed her neurology residency at the University of Michigan and her neuroimmunology fellowship at the University of Colorado. She has a clinical and research interest in the intersection of women's health and MS. So on that note, Dr. Shah, please take it away.
Awesome. Thank you, Libby, for that introduction. Hi, everyone. Welcome, and we're so excited you're here. We're going to spend the better half of the next hour talking about MS and pregnancy. And as Libby said, we are so thankful to the IOMSN for hosting us. And as part of the Neu-Ring platform, so we are neurologists advancing women's health and reproduction and innovation group. And so I wanted to share just a quick little slide with our mission statement, which is to galvanize advances in women's health research and neuroimmunological diseases through adaptive, flexible, national and international collaborations in MS, NMO, and MOGAD. So this is our panelists. If you have to cut tonight short and can't listen, or you just want to hear this talk multiple times, we do have multiple other opportunities for this similar webinar with a few of my colleagues, as listed here on the screen, Dr. Graham, Dr. Rawson, Dr. Sumasha. So here's a few of our disclosures. And then let's go through our agenda. We're going to start off by talking about general MS and pregnancy overview. Then we'll dive right into DMT or disease modifying therapies as it relates to pregnancy, and then look at things on the other end of pregnancy, which is that postpartum period, including breastfeeding. So let's look at MS and pregnancy just overall, just a broad view lens. So when we think about ideal pregnancy planning, and I will put a little bit of emphasis on ideal, we know things don't always go ideally, but if we had our ideal scenario, we would ideally like stable disease activity, which means no clinical relapses or MRI worsening for at least 6 to 12 months. In an ideal world, pregnancies would be planned where we think about timing the stopping of disease-modifying therapies as well as symptomatic medications with both an MS specialist as well as your obstetrician. There was a 2025 study that showed that now about 85% of patients with MS were on disease-modifying therapies up until the point of conception. And then before actually pregnancy planning, thinking about before conception, making sure that one is starting prenatal vitamins with at least 400 milligrams of folic acid and vitamin D 2000 international units a day. But what happens when we can't do ideal planning? And I think that's always a really good question because, like I mentioned, it's really nice when things go ideally, but sometimes challenging when things go in a different direction. And those are times where I think we really want patients to lean in and have these joint decision-making conversations with their neurologist, thinking about how we can go about making sure that you stay as safe as possible during a pregnancy from a disease standpoint, and then also making sure your baby stays as safe as possible too. So let's talk a little bit about fertility in MS. We know infertility rates are shown to be more or less the same in MS versus the general population. And we don't think that particular disease-modifying therapies necessarily affect fertility, although in some cases, stem cell transplants have been shown to cause premature ovarian failure. When we're also thinking about fertility in MS, it is also important to think about, well, what about the utilization of fertility therapies or treatments? This includes things like in vitro fertilization, IUI, things like embryo transfers. And so when we think about the utilization of fertility treatments, what's been shown is that this is low risk in treated and well-controlled MS. We also have some data that might show the utilization of continuing disease-modifying therapies while you are also undergoing fertility treatments to also make sure that we're also controlling disease activity. When we are thinking about fertility in MS, for those of you that are unaware, we kind of think about this idea of, well, at what point is there a referral to a fertility specialist? And in general populations, the thought is if you're under the age of 6 or 35, if you have attempted pregnancy unsuccessfully for about 12 months and have not conceived, then that's when you consider that referral to a fertility specialist, and 35 or over if it's over 6 months. But really in MS, sometimes we consider earlier referrals to reproductive endocrinology and infertility specialists. I've never met a fertility specialist that's ever said, you've sent me a patient too early. What is the MS effect or impact on pregnancy outcomes? We know that MS does not cause an increased risk of miscarriage. MS does not cause an increased risk of congenital malformation. It does not inherently mean that you are a high-risk pregnancy. There's no reason to change the method of delivery, meaning thinking about anesthesia that you use due to MS, thinking about things like epidurals or spinal anesthesia if you're having a C-section. There are no more frequent inductions or operative interventions seen in more modern cohorts with MS patients. And there is this idea of possibly this association with lower birth weights in infants, but we have not necessarily seen that to be clinically meaningful, meaning a higher risk of neonatal ICU stays or hospitalizations. There is this big pregnancy registry from a group called MS Space, which is a large collaboration between multiple centers, and we'll continue to get more information as time goes on. So again, taking a large overview look of MS activity during pregnancy, I would say this is probably one of the first descriptions of how MS did during pregnancy. So just to orient you on what this chart means, the bottom section there is broken up into 3-month trimesters, with the y-axis showing relapses per woman per year. And when we're looking at this big gray rectangular box in the middle, that is illustrating the first trimester, second trimester, and third trimester. And so what we're really looking at is relapse rates over time. And what we saw in this population was really a sudden or a dramatic decrease, especially by that third trimester, in relapse rates, down by about 70% compared to where they were before pregnancy, and then a significant increase in relapse rates following the delivery of their baby. Again, about a 70% increase from preconception rates. And this was in a cohort that was not really commonly on disease-modifying therapies. This was a cohort from the late 90s, early 2000s, and a lot of these patients were also perhaps potentially more significantly impacted by MS. And we're before the more modern advent of our McDonald criteria or a diagnosing criteria for MS, which allows for more inclusivity and earlier detection for MS. So what increases the risk of relapses during pregnancy? So I just showed you a slide that showed that relapse rates decrease during pregnancy, but what increases that risk? We know higher rates of relapses before pregnancy can increase that risk. Being off MSDMT for long periods of time, and then discontinuation of some MS medications that can cause rebound disease. And particularly, we think about those as our trafficking medications or our trafficking disease-modifying therapy medications, things like natalizumab or our S1P medications. The examples of which are fingolimod, ozanimod, siponimod, and I'm trying to think, what's the other one I'm forgetting? One of the others. It'll come to me. And then what about when we're thinking about evaluating or treating relapse in pregnancy? When we think about it from a global standpoint, MRI scans can be done safely during pregnancy, but we usually think about this need to avoid contrast. The contrast agent we use in MRI scans is called gadolinium. And then steroids can also be used during pregnancy. There have been some older studies that show this very slight increased risk of cleft palate and low birth weights if steroids are used during that first trimester. But I think often this prompts a discussion with the obstetrician that is taking care of you. And in the situations that I have needed to use it, I have never had an obstetrician tell me that we shouldn't use steroids. So let's jump ahead to pregnancy itself, thinking about disease-modifying therapies in pregnancy. We're going to particularly focus on the timing for stopping before conception and the risk of use of continuing during pregnancy. So here we've kind of broken out our disease-modifying therapies by classes. So when we think about our injectable disease-modifying therapies with glatiramer acetate, otherwise known as Copaxone, there's extensive safety data with no reports of fetotoxicity and can really be used up until conception and throughout pregnancy. Our interferons, again, also extensive safety data with how long they've been out and can be used up until conception. We'll go through our oral disease-modifying therapies. The overall rule with most of these is they should not be taken during pregnancy. One of the main reasons for this is all of our oral medications are small molecules. And you can imagine the reason they're taken orally is because small molecules are absorbed. And so in that same vein, small molecules can pass through the placenta to get from mom to baby. So the overall rule is these oral medications we use for MS should not be taken during pregnancy, and that includes our S1Ps, our teriflunomide, and our fumarates and cladribine. One of the things that I did want to point out is there is a black box warning on teriflunomide, otherwise known as Aubagio, that talks about embryo-fetal toxicity. This is certainly something, if you have an unintended pregnancy while you are on teriflunomide, should be something that's discussed with your neurologist. There is an accelerated drug elimination protocol that can help accelerate how quickly teriflunomide gets out of your system, making that, with the accelerated drug elimination protocol, take 11 days as opposed to 8 months. When we look at our infusible DMTs, focusing in on that second one there, natalizumab, its other name is Tysabri. There's also a biosimilar on the market named Tyruko. This may be safe to continue during the first 2 trimesters with discontinuation in the 3rd trimester. We often consider extended interval dosing during pregnancy, so spacing that out from every 4 weeks to every 6 weeks. And there is this risk of rebound disease associated with cessation. Dr. Helwig had a very interesting study that looked at relapse rates in individuals that stopped natalizumab use either right before pregnancy or in that first trimester. And one of the most meaningful pieces of data from this article was that about 11% of women may retain clinically meaningful disability from pregnancy-related natalizumab cessation relapses 1 year postpartum. So meaning that in those individuals that stopped the use of natalizumab right before or very early on in pregnancy, that there was a significant disability associated with that. So that's often why we think about continuing natalizumab use until that third trimester, usually during weeks 30 to 34, depending on how the timing goes on. One of the reasons we don't continue using this throughout the entirety of pregnancy is there is a risk of reversible blood count abnormalities in the baby. So that's why we really try to minimize third trimester use. If that is something you are using throughout the third trimester, we do often recommend checking baby blood counts when they are born. And then going to our next set of infusible disease-modifying therapies, thinking about the anti-CD20 therapies, we have several in the IV formulation, which is rituximab, ocrelizumab de novo, and then ublituximab, as well as ofatumumab as our subcutaneous option. The half-life for these medications is somewhere between 16 to 28 days. And what a half-life means for these medicines is how long it takes for a medicine to go from 100% in your bloodstream to about half. And then the second half-life is 50% to about 25%, and so on and so forth. And so when we're thinking about medications, we often think about this idea of 5 half-lives means near complete elimination of medication. So ofatumumab or Kesimpta is on the shortest end with that 16 days half-life. And then rituximab is on that longer end, that 28 days, with ublituximab or Briumvi and ocrelizumab or Ocrevus somewhere in between at 22 and 25, 26 days. When we think about when someone is taking one of these medications, how does this medicine get from mom's circulating system to a developing fetus? And so really, because these are larger molecules, unlike the oral medications that we talked about that are smaller molecules, you really need a placental receptor to help move those molecules from mom's bloodstream to the developing fetus. And so this is around weeks 16 to 22. And so sometimes we think about, well, how do we time these medications so that we can maximize how well they work prior to pregnancy, conception, but then also reduce the risk of this transferring to infants. So the prescribing information talks about maybe a 6 to 12-month washout, depending on which medication you're looking at. But I think most of us probably consider a shorter interval, just given we're thinking about how the half-lives work, as well as when these placental receptors develop. There was this really nice study, again, done with MS Space that looked at ocrelizumab's impact on what we call annualized relapse rates. So if you think back to our picture that we were looking at the beginning of this presentation, this would kind of be our gray box right there. And this green line is our interferons and glutathione acetate, which is Copaxone, so some of our older MS medications. And then the orange is ocrelizumab. And you can really see that significant reduction during pregnancy, but an ongoing significant reduction in that postpartum period, where we really saw significantly lower postpartum relapse rates. There is a study that was done by Genentech, the company that makes ocrelizumab and ocrelizumab de novo, called Minori, that looked at placental transfer for ocrelizumab in women that had MS to their infants. There were 35 women enrolled with ocrelizumab exposure less than 3 months before conception or during that first trimester of pregnancy. And really one of the core outcomes was looking at fetal blood work through umbilical cord blood, and found that this medication, the ocrelizumab, was undetectable in most infants. And the infant B cells, which is what this medication is affecting, were all normal for age. So take-home points during pregnancy is injectables may be continued up until time of conception, with glutathione use continued during pregnancy. Oral disease-modifying therapies should never be used during pregnancy. Anti-CD20 therapies prepartum may provide significant benefits through the first trimester and potentially postpartum. And then natalizumab infusions may be continued through the third trimester. So now we'll take it to the other side when we're really thinking about postpartum and breastfeeding. So thinking about risks in the postpartum period, disease control with breastfeeding, and DMT risks. So we're going to focus on, again, that chart that we thought about at the very beginning. We're going to focus on this red rectangle that we drew instead, which is really looking at that time right after delivery. There have been several studies that have demonstrated an increased risk of clinical relapses, meaning new neurologic symptoms following delivery, but also several studies looking at higher risk of MRI changes as well, meaning new MRI changes when we're comparing to the prepartum period in women as well as after delivery. So what is this postpartum relapse risk? It is really the highest risk of relapse in the first 3 months. So depending on the study you look at, somewhere between 13 to 32% will have a clinical relapse. And we think the risk factors that contribute to this higher risk of relapse depend on what kind of medication you use before getting pregnant, how often you are having relapses before pregnancy and during pregnancy. We've seen higher disability scores associated with higher risk of relapses postpartum. We've seen not using disease-modifying therapies postpartum be associated with this. And I put this asterisk by absence of breastfeeding. There has been a meta-analysis, meaning a group of studies put together that show that in those individuals that were exclusively breastfeeding, meaning only breastfeeding every 3 hours, there was a 43% lower relapse rate compared to those that were not breastfeeding. But the reason I put it with an asterisk is I say that if you can breastfeed, that's fantastic. If you cannot exclusively breastfeed and need to rely on formula for your infant or fully on formula, I don't want that to make anyone feel bad because that's not always something that you have a full choice over. And then the other thing that we kind of think about in terms of assessment in that postpartum period is to really consider getting a new baseline MRI, meaning we're getting a new MRI to really look at what does your brain and spine look like now that you've delivered a baby. Resuming your disease-modifying therapy is something that's highly individualized. It's really something that should be a conversation that you have with your neurologist in terms of thinking about what is the severity of your disease, what is the plan from a breastfeeding standpoint, and what is your comfortability with the data that exists out there. The great news about MS in 2026 is there's continuously, especially in this field, new data coming out all the time. So a discussion that you might have had prepartum with your neurologist might not always be as up to date when you're having it postpartum. Just a little bit of background when we're talking about breastfeeding, just because I'm going to refer to some of this during our talk. When a woman first starts lactating after delivery, your breast milk goes through 3 different stages. It goes from colostrum, which is the initial breast milk, to transitional breast milk, to mature breast milk. And mature breast milk is usually present in most women around days 10 to 14. And this becomes very important because when we talk about the use of medications or the knowledge we have about medications in the presence or in the setting of lactation or breastfeeding, we're really talking about it in the context of mature breast milk. So when we think about injectable disease-modifying therapies, we're going to see a similar kind of theme to what we saw during pregnancy, which is that larger molecules tend to get into breast milk less, and smaller molecules tend to get into breast milk more. So for our injectable disease-modifying therapies like glatiramer acetate and interferons, we think that it's okay to breastfeed, and there haven't been adverse outcomes necessarily noted for breastfed infants. For some of our oral medications, again, similar to what we discussed with pregnancies, since they're small molecules, these should not be taken during breastfeeding. One of the exceptions with another asterisk is cladribine or Mavenclad. Because of the short half-life and how quickly it leaves your system, in theory, you could be breastfeeding 1 week after cessation or after you've finished a cycle of cladribine. Going to our infusible medications, when we're looking at natalizumab, because it is a large molecule, we have seen measurable but low amounts excreted into breast milk. When we think about some of these large protein molecules, we think not only is their breast milk passed there, or the amount of medication that's passed into breast milk limited just because of the size, but we think there's also partial destruction of some of these medications by the infant GI tract, which then also leads to minimal infant absorption. There have been several small studies looking at women breastfeeding while taking natalizumab. One study showed in 11 patients showed something called a relative infant dose, or RID, was 0.04%. And let me explain what the relative infant dose is. This is essentially a measure of saying when we're comparing how much is in baby's blood versus, or how much we're seeing relative of a medication from mom to baby. The FDA really considers anything less than 10% to be acceptable. And so when we're thinking about something as small as 0.04%, that's obviously well within that, less than 10%. There was also another study done by Witt et al., published just recently, that looked at 125 women and did not see any association of hospitalization, systemic antibiotic use, developmental delay, or issues with weight at follow-up visits in those individuals. When we forward to anti-CD20 therapies, again, thinking about the combination of our ocrelizumab, ofatumumab, rituximab, and ublituximab, similar ideas, these molecules tend to be large. So we think about limited passage into mature breast milk, as well as partial destruction by the infant's GI tract. If we're looking at that relative infant dose, most studies have found the relative infant dose in these medications to be less than 1% as well. There was also a study that was wrapped up just last year called Sopranino. That was a phase 4 study looking at the transfer of ocrelizumab in breastfeeding women with MS to infants. And there were 13 breastfeeding women on ocrelizumab enrolled in this trial, and they found negligible amounts of ocrelizumab in breast milk, and then also tested infant B cell levels that were found to be normal. And a few other studies have also looked at these infant B cells as well as relative infant dose and found similar outcomes in ocrelizumab and then as well as ofatumumab. There is an ongoing trial that is no longer enrolling, but looking at the role of Kesimpta in the setting of breast milk as well. So take-home points for breastfeeding. Injectables can be continued while one is breastfeeding. Oral DMTs should never be used during breastfeeding. Most of the available information we have about disease-modifying therapy transfer into breast milk is available in the setting of mature breast milk. Anti-CD20 therapies may be safe with mature breast milk, and natalizumab infusions may be safe with mature breast milk. And so we flew through that quick. So we wanted to thank you for this time, and maybe I'll turn it over to Libby and see what kind of questions we have. I do have the IOMSN website and the Neu-Ring website there at the bottom, full of lots of good information. And as Libby mentioned, this webinar will be recorded and posted on IOMSN in case you wanted to recap some of the points that we talked about.
Thank you, Dr. Shah. That was really informative and helpful. So we have a couple of questions. I think we did want to hear a little bit about the treatment of neuromyelitis optica spectrum disorder and MOG antibody. If you have access to those slides, specific question, which maybe there's some limited data available that you could speak to on whether or not satralizumab and the complement inhibitors, eculizumab and ravulizumab, are what the consensus is on whether or not those are safe in pregnancy and breastfeeding.
Sure. Why don't I will just advance to my next slide, which is neuromyelitis optica spectrum disorder and family planning. So I will probably just highlight, I think, those key questions. But when we think about fertility, there's not as much data about fertility in NMOSD. Pregnancy planning is actually very similar. One of the things that's interesting when we think about pregnancy course and NMOSD is that ideally we would like clinical stability for just a little bit longer prior to pregnancy if we can, just because we know relapses are associated with higher risk of disease disability or clinical disability or disease accumulation. In an ideal world, 12 months would be great, but I mean, sometimes things happen. The other thing that we consider that's a little bit different from what we talked about with MS is consideration of monthly growth ultrasounds. as well. There are some immunologic changes that happen during pregnancy, which might help us hypothesize why we might see a higher risk sometimes in some of these studies of NMOSD relapses during pregnancy, as well as a slightly higher risk of miscarriages. There is aquaporin 4 expressed on cells in your placenta. And we've seen in animal models that perhaps there's an increase in also these aquaporin 4 receptors in the brain during and after pregnancy too. And so maybe that's one of the things that also increases the susceptibility to NMOSD attacks. So we also, well, I'll skip ahead just a little bit. When we're kind of thinking about relapse management, and I think this is similar, but just a little bit different than when we talked about MS, is similar things with the steroids, but we will also use plasmapheresis quite a bit in NMOSD. Things that we watch for here is plasmapheresis can cause hemodynamic shifts, meaning it can cause relatively low blood pressures while you are engaged in plasmapheresis. So we're really careful with making sure that we're not altering that too much. And then we also want to pay special attention to moms that have that Rh factor. And if moms are Rh negative, that we're looking out for potentially getting Rh immunoglobulins through some of that. We talked a little bit about miscarriage risk, but I will go forward to the risk of these medications during pregnancy and then also postpartum. When we think about some of these medication uses during pregnancy, I think similar to kind of how we discussed with natalizumab and the anti-CD20 therapies, eculizumab and inebilizumab and satralizumab are all considered larger molecules. So we think that some of that data about them not being able to pass through the placenta until later on in pregnancy is probably applicable. Interestingly, with eculizumab in particular, there have been small studies in patients with a different disorder called PNH or paroxysmal nocturnal hemoglobinuria that showed that when those patients delivered and it was tested for their cord blood was tested for eculizumab, there was low concentrations seen there. When we're thinking about the other side of things, thinking about relapses postpartum, similar to MS, we do see higher rates of relapses postpartum, and we really want to think about resuming disease-modifying therapy as soon as we can, especially for those that have had more recently active disease. And I think this again becomes more important because we know the severity for relapses in NMOSD is higher. The other thing I pay attention to, particularly in my NMOSD patients postpartum, is really monitoring for any sort of blood clots, which are deep vein thromboses or DVTs. There is an estimated increase by about 30-fold in that postpartum periods in NMOSD patients. One of the challenging things is that we don't have as much data that I'm aware of on breastfeeding as it relates to relapse, if there is a decrease in relapse rates with exclusively breastfeeding or partially breastfeeding. But when we think about disease-modifying therapy use during the course of breastfeeding, again, similar to kind of what we've thought about larger molecules, likely are harder to get into breast milk with, I think it was eculizumab that you particularly asked about. There's undetectable levels seen in breast milk. And with satralizumab, not a ton of data, but again, kind of thinking about the size of the molecule and how it gets through, we think likely minimal transfer, but we have limited information there. I might just finish the last slide, which is just what is relapse management when we're thinking about in the postpartum period for NMOSD patients. With the use of IV steroids, we think the peak passage is into breast milk about an hour afterwards. But after that, really how much the baby's little adrenal glands are making in terms of steroids, you're not actually getting more in breast milk than that. And there's no issues with plasmapheresis in terms of breastfeeding. And then did you say MOGAD as well, or was it just NMOSD, Libby?
There was a particular interest in MOGAD as well. If we have any data, though, I could understand it's a little bit limited.
Yeah, I don't have any necessarily particular slides on that, so maybe I'll just stop this share so we can discuss. But when we kind of think about MOGAD data, and there is ongoing data that's being collected in MOGAD patients. I think the data is a little bit conflicted in terms of, are we seeing more or less during pregnancy? One of the nice parts with MOGAD is if we're thinking about what is the use of our disease modifying therapy during pregnancy, if we're thinking about IVIG or IV immunoglobulins, that can be continued during pregnancy. The main thing to pay attention to with the use of something like that is really, we know IVIG is just a heavily proteinaceous fluid, right? Because it's just full of proteins. That means it's like thick and it increases the risk of blood clots, which pregnancy on its own already kind of does. So really making sure that we're paying attention to clotting. If you do have MOG antibody disease, Dr. Houchins from Brigham is actually running a study right now looking at MOGAD in the context of pregnancy. And I think it's a few different surveys throughout the course of pregnancy and postpartum. So if you're interested in doing so, it would be great to have you contribute to that.
Thank you, Dr. Shah. Another question came through about wondering if you're using anything to kind of prophylax the relapse after some of those therapies that you had mentioned predisposes people to rebound relapses. So steroids, either oral or intravenous. Um, if there's data and or what are you doing in your practice?
Yeah, as far as I'm aware, there is not great data on the utilization of steroids to prevent relapses when it comes to the rebound disease activity that happens with natalizumab or some of those oral S1P medications. In my practice, in general, as most of my patients know, up until the age of 45, I'm going to pester you about family planning plans every visit, even if that's not something on the agenda. And I think it's just to make sure that we're planning as much as possible. And so if I have someone that's on one of those medications and we're planning on a pregnancy, what I will usually do in lieu of doing steroids or something like that, my typical practice, if someone, for example, is on Gilenya or fingolimod or one of those S1Ps, is I might transition them to an anti-CD20 therapy and give them a singular dose before conception efforts.
Okay. One of the questions that I get from my patients a lot is specifically uh, during delivery. Is it safe for somebody to get an epidural or spinal anesthesia?
Yeah, really great question. I think there was a really old, not well done study that has somehow circulated amongst anesthesiologists about patients with MS being at higher risk of relapses with anesthesia and with epidurals, which has not been validated. So I would say if you want the epidural while you're having your baby, get the epidural. And if you don't, that's totally fine too, but there's not a concern necessarily from an MS perspective. Um, if we don't have other questions, I might have something else that maybe I would throw out there too. I think one of the things that is very important when we're thinking about the postpartum period is looking at postpartum depression and anxiety. We know that that is a risk in general after having babies, but we might see a higher rate of that in MS patients, and I think especially when you're thinking about the confounding, I'm not getting great sleep. The baby is not eating or not doing X, Y, or Z, and we're worried about some of those things. It may be hard to sometimes pay attention to what's going on with yourself. And I would say really empower everyone on this call to make sure that you're paying attention to your mental health, making sure that you're paying attention to also what you need for your well-being, because the baby can't be well without you being well.
And is there anything that I think that's really important to note. It's something that's really overlooked in healthcare today. But another thing that can sometimes be overlooked is there anything that can be done to optimize our health physically postpartum, specifically relating maybe to pelvic floor physical therapy?
Yeah, really good question. So let's talk a little bit about symptomatic management after delivery. So we talked a little bit about mental health really, really briefly, but when we think about this idea of relapses too, when we spent a lot of time talking about relapses, I think the other thing that we kind of skimmed right over is what is our risk of what we call pseudo relapses, or I like to call it recrudescence after delivery. And for those of you that have not heard that phrase or that term before, that is essentially saying, I'm not necessarily having new neurologic symptoms or something that correlates with new disease activity, like a new lesion on my brain or spine, but rather I'm feeling that symptom that I've had before with MS. So if I've had optic neuritis before, maybe it was a decade ago, I've delivered my baby, I'm not getting great sleep in the setting of that stressor, I might start going, oof, I'm feeling my vision go again. Now, it can't be recrudescence or a pseudo flare if you've never had that symptom before. So just to clarify that, but making sure that we're paying attention to kind of some of our internal body markers for pseudo flares or recrudescence. But to Libby's point, the other thing that we see in MS quite a bit, and also in neuromyelitis optica and MOGAD, is what we call neurogenic bladder, which can be bladder symptoms that are characterized by an urgency, frequency, sometimes incontinence, which are all things that can be accentuated by the fact that you've had this little human in your uterus pushing down on those pelvic floor muscles over the course of several months, plus all of the hormonal changes that happen during pregnancy and postpartum, in addition to any potential complications during delivery, including like tears and stuff like that. So if you're in that situation where some of those urinary symptoms, some of the bowel symptoms, even sexual dysfunction feels more accentuated after delivery of a baby, pelvic floor physical therapy with a certified pelvic floor physical therapist can be incredibly, incredibly helpful. Other symptoms that might worsen after delivery might include fatigue. One of the things that becomes challenging is knowing what the safety of some of these medications, if you're using a medicine for fatigue and MS, can be. But thinking about really energy conservation as a mom of three, I don't know that I ever really got into the sleep when the baby sleeps. I have a 10-month-old right now, and that's has not worked for us for either the other two kids or this 10-month-old. But really thinking about how do I use energy where I need to use energy? Can I outsource if I can outsource? Can I safely hand the baby off at night to help make sure that I'm getting the energy and rest I need? I think it becomes incredibly important in MS as well.
It's true. And I think it speaks to the importance of getting set up with a provider who really works closely with MS patients, NMO, and MOGAD patients around delivery, just so that we can have these conversations with our patients and anticipate, you might need to have this, to figure out how to have someone on hand to help you to preserve your energy. And so if anybody does feel like a consultation with any of the Neu-Ring providers is needed, on our website, you can see in your area, we're all across the country. I'm sure any of us would be happy to fit you in and just try to meet with you one-on-one to talk through what your pregnancy planning, intrapartum, postpartum life might look like.
Absolutely. I think that's a really, really good point. And I think even if it's not meeting with one of us, I think we all know people everywhere. And so even if it's, I necessarily can't travel or video call with X, Y, or Z, I mean, we can always help find you someone that might be able to support you through that period if that's something you desire or want to get more information about. And like I mentioned, along the course of the talk, this data is constantly changing. It's very different than it was 5 years ago and very different than it was 10 years ago in terms of recommendations for pregnancy, for breastfeeding. Dr. Beauvais, who's on the call, was a huge instrumental part of pushing that forward for women's health, I think, in MS. And so really just making sure that just because this is information that's current right now does not mean there won't be updated information and more ways to do things safer and in a way that's safe for you and baby a year from now.
Yeah, certainly even in the last 10 years since I've been working, we've changed our methods like tremendously for the better. And I think that's really true. So nobody else has come through with any questions. So last chance for Q&A. I think we're set. Is there anything else that you wanted to add, Dr. Shah?
I don't think so. The only other thing I might throw in there, which is like before pregnancy, is making sure that if you're planning on getting or if you're not planning on getting pregnant and you're on some of these medications, making sure you're on a good form of contraception, so that there's not an unintended pregnancy. I think that's all I've got if no one else has any other questions.
Oh, we just got one more. Maybe we can talk about Dr. Beauvais' study here. Somebody just asked about race differences and outcome in pregnancy.
Yeah, and I wonder, I don't know if Dr. Beauvais is available or can discuss that at all.
Oh,
Hi.
there she is.
Hi, everybody. Yeah, so that's a great question. I think we know that in the US in general, there are really sort of unacceptable differences in outcomes for pregnant women and their babies according to the color of their skin, where they live, what healthcare they access, and more. And we did do a study a few years back. Many of our Neu-Ring members kind of collaborated and we shared information about our patients who were Black, Hispanic, or white and looked at their pregnancy outcomes. And what we saw was from a general perspective, women who were Black or Hispanic were slightly less likely to breastfeed for longer, slightly less likely to have their sort of first trimester ultrasounds. Black women were more likely to have crash cesarean deliveries. So those are all kind of findings that match the general population. When we looked at the MS specific outcomes, were women on medication? Did they have relapses? Things like that. We didn't really see differences in terms of the MS related outcomes between Black, Hispanic, and white women. So it kind of suggests that the MS care they were getting was, appropriate as much as anyone's is. So we didn't see disparities there.
Thank you. That's incredibly important. Any other questions?
I think that's it. So thank you again, Dr. Shah, Dr. Beauvais, for jumping in, putting you on the spot there. Um, and to Kathy Costello and Lenny Almeida at the IOMSN for hosting this webinar. And we hope to see you all for a refresher, or maybe tell some of your friends if you want to have them join for the next webinar, which I'm not sure if the schedule is up yet. But we will be sending out emails and you'll be hearing from us all soon. So thanks again.
Thank you, everyone.